Welcome, everybody. My name is Dr. Josh Funk, and this is the first episode of the Strength and Knowledge podcast brought to you by the R2P Academy. I am very, very happy to bring to you today my right-hand man and our resident ACL expert, Dr. Zach Baker. Welcome.
Josh, thanks for having me. I'm excited to be able to go through this with you today.
Well, Zach, I've obviously known your story for quite some time now, why you have a passion in the field of PT, but not only that, why you have a specific passion for ACL injuries. Share a little bit about kind of what brought you to the point where physical therapy was an interest for you, and maybe what your path to this point has been.
Yeah, absolutely. So just a little background on me. Undergrad, went to Salisbury, was an exercise science major, planned on going more of like the strength and conditioning route. While I was in high school trying to figure out what I wanted to do for college, I actually sustained 2 ACL injuries. So had my first injury my junior year of high school, came back from that, had my second ACL injury my senior year of high school. And then in between those, I managed to have a dislocated shoulder with a labrum and a rotator cuff tear. And then the following year, my freshman year of college, dislocated my other shoulder and had a rotator cuff and labrum tear. So I've gotten to see the rehab side of things from a post-surgical standpoint with the knee injuries. I managed both shoulder injury without surgery. And that's really what got me to switch from going down exercise science, strength conditioning, and decided to continue to pursue education in the physical therapy field, going to PT school, and ultimately what led my interest in trying to navigate this whole post-op process for athletes as they're getting back to the field of play.
So for you, you obviously have had firsthand experience of this. You have gone through, I'd say, over the past 5+ years of us working together, probably working with hundreds of post-op knees, but in particular, people with either single ligament or multi-ligament reconstructions. What is something that you've noticed, really a big shift, both in the education and the clinical application of ACL rehab that's really changed over not only the past 5 years, but from your experience also going through the process yourself?
Absolutely. It's been a little over 10 years since I've gone through the process myself, so things have changed significantly since then. And even in the last, 7-8 years that I've been practicing, and 5 to 6 years that you and I have been doing this with our team at Rehab to Perform. And I think one of the biggest changes I've seen is going from strictly a timeline-based protocol treatment paradigm to something where we are now still appreciating the timeline components of the protocol and the phases of progression, but also trying to establish some subjective and objective criteria along the way to help guide and facilitate our decision-making process of how we're progressing this athlete, or recommending maybe to halt on some of the progressions with these athletes, especially when it comes to return to play decisions.
Yeah, I've seen that with you. I know we've talked a lot, there are timeline considerations, obviously with that 9-month mark being something that is critical to many people, especially if you're just looking at the statistics of ACL rehab and having ideal outcomes. But then balancing that out with criteria-based benchmarks, right? Having an athlete actually meet certain criteria that almost unlocks, new activities or things that they're working on. If we just talk about our return to run progressions, but what are some things that you think young clinicians need to focus on the most when it comes to ACL rehab and really their clinical decision-making process when they're first working with somebody at that initial eval and then planning forward?
Yeah, I think the biggest thing that you have to do is you have to get an idea of what the big picture looks like for these individuals, meaning when are we starting with them? When are we finishing with them? What is our overall time frame that we have to work with them? and what kind of situational urgency do we have with them from a internal and external factors that may be weighing on the decision. So I don't think the concept of criteria-based rehab is new. I think a lot of the timelines and protocols that have been established are based off the assumption that certain criteria are being hit. I think what we've really tried to do at Rehab to Perform, and I think what the entire profession is really trying to do, is finding ways that we can hold ourselves and the athletes accountable by establishing criteria and really how we are testing, measuring, and monitoring those along the way.
It's interesting you bring up those words, right? Tests, measuring, monitoring. There's a small segment, I would say, of our profession that is not as big of a fan of some of these return to sport style testing. What would you have to say to somebody who's maybe trying to figure out whether return to sport testing matters and what they would incorporate as a part of their return to sport testing?
Absolutely. I think we live in an age where we have a lot of information available to us. We're constantly trying to learn more. There's constantly more research coming out with some of these return to sport tests that we're creating, and really how effective they are, what kind of role that they play. And when it comes to testing, I look at it from a return to sport standpoint. It's no different than early on when we're using certain criteria such as pain scales and goniometric measurements to monitor range of motion and circumference measurements. We commonly agree that all those are worthwhile and all those are valuable in making sure that we're progressing in the right direction, and that we're catching things in a quick fashion to act on them. I think return to sport testing is the same thing. We need to figure out what qualities does our athlete need to possess to safely and optimally go back to the field of play from a fitness standpoint, from a movement standpoint. And then we need to try to find tests that really match up with what those qualities are. And I think as clinicians, we need to appreciate no single test is going to give us all of that information in and of itself. But if we can find a cluster of tests or a battery of tests that we utilize along the way and appreciate that each one of those tests is going to give us a piece of information that's relevant to that athlete, it allows us to have enough data points to make very objective based decisions on where this athlete is and what the most logical step is, not only from a return to sport standpoint, but is this athlete doing what we need them to do from a programming standpoint as well, or is there anything that we need to change in the short or long-term future with this athlete?
And just piggybacking on that, I mean, I think something that we've discussed often is that no one specific test is the end-all be-all or the deciding factor. It is this aggregation of multiple points, looking at a variety of different qualities. You brought up pain. We could go range of motion. What kind of elastic benchmarks? Maybe there's certain things we want performed at certain tempos or certain competencies. So it's one of those things where I think looking at our process and even what we've done 5 years ago, these different data points have continually evolved. What are some newer things that we're doing as a team to evolve our process for return to sport decision-making over, say, the past year or so?
Yeah, so I think one thing that we do a great job is just a collective brainstorming of our entire clinical staff across all of our locations. We utilize all of the clinical DPT students that we have as well, just sharing collectively on the experiences that they have had and they have seen also. And we continue to just self-reflect on, what we're currently doing with our athletes, what patterns and trends we're seeing, and if any of the patterns and trends that we're seeing matches up with the evidence and the research that's out there. And I think to give people a little clearer picture from a return to sport standpoint, we're trying to make sure that we're hitting all the buckets with the athletes. So we're looking at pain and symptoms. We're looking at range of motion. We're looking at strength. We're looking at force and power production. We're looking at different movement qualities and capabilities. And within each one of those buckets, we have 1 to 2 tests that we are looking at. And I think what we really do is we just sit back and we figure out, is the test that we are performing telling us what we are hoping it is telling us about this athlete? And more importantly, what is it not telling us about this athlete from a physical attribute? And whatever it is not telling us, is there something out there from a testing standpoint that we can do consistently and reliably, and I think more important, feasibly within our clinics, so that it becomes just standard practice?
So to dive a little bit deeper into that, is there specific tests that you think have better allowed us, if we look at our return to sport checklist? That's obviously not something we're doing with everybody. Most likely we're adding certain things to go from general preparation to more specific preparation. But let's talk specifically actually about the lateral profiling and how we're focusing more on that over the last year or so.
Absolutely. So to expand off that, something that we have done and that's been done in the profession is hop testing. And I think hop testing gives us a good idea of single leg force production and absorption for our athletes in a single and repetitive contact manner. Unfortunately, the only one that has any sort of lateral component to it is that triple crossover hop. So things that we are also doing with our athletes from a lateral profile standpoint, from more of a rapid response standpoint, we're looking at the 30-second lateral line hop test. And then we've expanded off of the traditional hop testing by adding in a single leg lateral hop and land. And then from a programming standpoint, we're also doing things along the lines of lateral broad jumps. So doing, bilateral jump to bilateral landing broad jumps, in addition to single leg jumping to single and bilateral leg landing. And we can do that from a testing standpoint, where we are monitoring the distance that they are covering. And then we are also doing that from a qualitative standpoint to look at if they are utilizing appropriate and pretty comparable movement strategies between each limb. And then also, is there any apprehension, and what's just their competency and consistency with performing that task? And you'd be surprised to see how many people can do well on the traditional testing, especially if they're familiar with that testing and they know what to expect, compared to something that is truly a lateral or rotational dominant pattern, and if it's a new and novel task to them as well.
Yeah, I mean, we've had people who have gone through that traditional 4-hop testing battery and then move into some of the lateral propulsion, if we just talk about the single leg broad jump landing on 2, or more absorption, which I would say is that rear leg propulsion, rear leg land, those particular movements having a significant asymmetry after that individual then just crushed what I would call more of that linear focused for test. But if we peel back layers here, and even we take it back to the beginning, let's say the first 3 months of rehab, what are some things that you, maybe even as a young clinician, feel like you missed, or some things that you think people maybe overlook, and it puts these individuals in a situation where maybe they're not making as much progress when we get back to, say, our return to run or some of our more change of direction focused progressions?
Absolutely. And I think when you look at your return to run, change of direction, even eventually getting to your hop testing, a byproduct of a lot of that stuff comes down to how, from a foundational standpoint, how strong is that athlete? How confident is that athlete? And what does their general GPP or just fitness profile look like? So early on in the rehab, in those first 3 months, I think we do a great job as a profession of just hitting, kind of all the nuts and bolts of PT school. We're getting symptom levels down. We're getting range of motion back. We're getting them ambulatory. But I think we need to find ways, and I think we do a great job of it at our clinic, of how do we optimize strength training during this time when we may be limited with what we can do from a mechanical loading standpoint? So something that we utilize in this time is BFR. And we utilize BFR for a lot of more of our protocol-driven activities, such as like your straight leg raises, your bridges, your quad sets, things early on where you can't just physically load them. And then as we get away from that and we get further into this in that 2 and 3 month mark, we're making sure that we're prioritizing the activities that we can load safely. So our ones that are in more of like a bilateral stance where balance and stability demands aren't as exaggerated. Maybe the range of motion isn't as exaggerated. We can load those up to get a true strength proponent to them. And we're supplementing that with more of our stability, proprioceptive work, almost as like fillers or accessory type work with them. And I think the other thing that you need to do during this time is how can we build a very good just aerobic base for them and a GPP base for them where once they are up and ambulatory, there's no reason why they can't do upper body work. There's no reason why they can't do core stability work. Maybe we're finding ways to work core and work upper body where there is a lower body stance demand or a lower body component to it as well. And you'd be surprised just from a mental standpoint, getting athletes to sweat again early on in the process is one of the easiest ways to get buy-in for them. It's a way to make them feel like an athlete again. And it's something where you can fill a lot of that kind of dead time within a session with very productive work that's going to lay a huge foundation for them to really take off when they get to that 3 and 4 month mark, where as a PT, I think that's where the most fun part is, taking them through those progressions.
You're talking about sweating, and you also brought up things like supersets and, knowing you, also some trisets. When I think of that kind of, a programming format, I think of the word density. You combine sweat with density, and sometimes the really, and a big word that we're using more and more is reconditioning. What are you doing to ensure that your athletes are actually in the position where they can handle a program with more density, where they're going through an A, B, C in consecutive fashion before resting?
Yeah. I think a lot of that comes down to you just start with stuff that you know that they can handle and you build and you layer from there. So, simple things early on where you're giving them maybe a more physical challenging thing with their upper body that has no lower body demand. So I'm thinking of, early on, they're just weight bearing. There's no reason why they can't do rows with the TRX. There's no reason why they can't have their hands on the table doing push-ups in that elevated position. And they're still working, essentially a quad set or a terminal knee extension in both of those positions. And that's something where you lay the framework for these supersets and these trisets where, hey, you're 2 weeks out. We're just getting you, fully ambulatory off the crutches. We're going to walk down and back on the turf. When you get back, you're dropping into a 30-second plank, and that's going to be your rest break. Then we're going to hop up, and we're still going to focus on that locomotive component specific to your ACL. Instead of going forwards, we're going to walk backwards. And guess what? When you get to the end of the turf, we're hitting another 30-second plank. Then we're going with a side step on the way back. And before you know it, only 3 minutes has passed in the session. You've hit 3 sets of 30-second front planks. You've covered 3 different locomotive patterns. You've gotten that person in an upright position, in a parallel position. So you're working on just a lot of these different things where in the grand scheme of things, all they know is they've just done a little core workout and they've learned how to walk again. And you've covered no more time than it would have taken to get an exercise ball off the rack and do, bridges and leg curls with somebody. And I would argue you've set a lot of precursors for things that you can do down the road. You take that same athlete you're doing locomotive patterns with, the next time they come in, you're getting a 4-inch block out and you're doing 30-second step intervals. Hey, we're going to do step ups on the block for 30 seconds, and then we're going to superset it with that front plank. Then we're going to do lateral step ups onto the box. So you take all of these foundational principles, you start in a very, basic manner, and you just find ways that as the post-surgical protocol allows and as their abilities allow, you add one little wrinkle to it, and you just keep pushing that envelope of what's physically taxing and safe at the same time.
I think an important word that comes to mind when you're talking about some of that stuff and you're making it about more than just their injury and you're training the whole individual is the word identity. I think oftentimes with an injury, athletes' identity is compromised. And obviously with some of the stuff that you're mentioning in the earlier phases of rehab, it helps them kind of regain their identity, see themselves as more than just that particular injury. But I know firsthand that you also do a very, very good job in later stages of rehab to really, really make things fun, make it enjoyable. There's a high level of engagement, and especially during a time where sometimes athletes might drop off a little bit more. They're feeling a little bit better. They think that they might be okay, but you do a great job of keeping connected with them and engaging them. What strategies do you recommend for people who maybe are struggling with that end stage of rehab?
I think the first thing that you can do, and I'm glad that you bring that up about making things engaging, because I think you go through periods of the post-op process early on where you make gains, and then you're in that just 6 to 8 week period where you're just going in and you're just hustling and you're sweating and you're going through the process. And you need to find ways to keep adding flavor to that to make it interesting. Then you get into that 3 to 4 month mark where you've learned to run, you've learned to do the multi-directional work. Now, how do we make the drill work more fun? And I think the biggest thing you can do as a clinician is learn more about your patient, their activity, the sports that they play, and what they enjoy doing. I have a volleyball player right now. I've never played volleyball before. I have no clue what volleyball drills or volleyball practice looks like. I'm learning more about her sport, and as I learn more about what her sport entails and what it looks like, I'm taking drills and concepts from that sport, and we're putting it in with our general, our cone-based agility work or some of our other movement work that we're doing. So I think the ways that you drive engagement is you either make them game or context dependent with their sport or activity of choice, or you make it conditioning and criteria or objective based, where you're saying, hey, we are shuffling, we're going, lateral conditioning right now. So we've got cones at 5-yard intervals. Within those cones, we need to go side to side 12 times within 30 seconds. If we do not hit that, guess what happens? And you give them some sort of consequence, or you give them some sort of thing that they need to build off of with that. And I think you make things context dependent, you make things game dependent, you put something on the line, and people tend to thrive off of that, especially if you're working with athletes. Give them something that they can't do, or tell them that you're giving them something that they can't do. And I think they're going to surprise you in regards to the effort that you'll get out of that.
Yeah, I mean, when you talk about challenges, you talk about gamification a little bit. I think that's just a direction that the profession itself can continue to work towards as we're putting things out there that go beyond PT. They really focus a lot more on just the general health and wellness of the athlete. But Zach, to close today, what are some general just recommendations that you have for some of the younger clinicians that are trying to build out their niche in ACL rehab?
I think the number one thing that you can do is reach out, explore and reach out to people who work a lot with ACL rehab. There are a lot of people out there and a lot of clinics out there that say they do ACL rehab. Unless you're talking with somebody that works with individuals of varying ages, of varying skill sets, and sees them with a high frequency, I think a lot of stuff that I have learned and that I've learned from other people are from ones who have done the best job of not only treating a high number of ACLs, but really continuing to learn more about it, either through what the research is showing or through what other individuals of the field are doing. And that's something that I try to do is I reach out, I would say weekly and monthly, to other people who I find I have a lot of respect for in the field that are doing things the right way. Run ideas by them, and just see what they're doing that's working for them. The other thing that I would say also is you have to be authentic. If you want to do ACL, and if you want to do any sort of return to sport or just higher level end stage rehab with people, you need to go through the paces yourself. I've written up a lot of what I would consider great ACL workouts for people. I will do them myself prior to giving them to somebody. And then I'm shocked to see either A, how underwhelming they are and just how easy it was, or B, how overwhelming it was, and realizing there's no way if I'm struggling with this that somebody who's only 3 or 4 months from an ACL could handle this in the given time frame of a session. So reach out to others. Don't let your ego get in the way, or just your insecurities get in the way of feeling like you don't know it all. And then 2, be authentic, put yourself through the paces, have a true appreciation of what you're asking this athlete to do. What does it really feel and look like? Because until you go through it, you have no clue what the different challenges and nuances of that activity really is.
Zach, I really appreciate it. Obviously, I've enjoyed just watching you evolve. Obviously, from our first day at Frederick Indoor Sports Center to where you're at right now. And I think that you're only going to continue to push into your level of, expertise and knowledge surrounding not only this topic, but just in the physical therapy profession as a whole. For the people who want to stay connected with you, where is it best for them to reach out?
Yes, so I am on Facebook and Instagram. Facebook tends to be more community-based for me. So if you're looking for things from a professional, clinical standpoint, on Instagram, my personal one is ZDBaker30. And then I also do a lot of things through R2P Academy, which is our continuing ed program that we have that we put a lot of resources on as well.
And you can also reach him at Dr. Baker at rehabtoperform.com. If you have any greater questions for the students out there, he is also in charge of our clinical internship program. For anybody looking for clinical rotations now and in the future, don't hesitate to reach out. But thanks for tuning in to the first episode of our Strength and Knowledge podcast. We greatly appreciate it.
Thank you.